Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Farden. I'm the organizer and chair of this thing. Thank you very much for joining us today. The Grand Round program is now full for the rest of this semester, which is great news for me, but we do have slots for next semester. So if you're sat there thinking, got a great presentation that I'd like to give to the greater Dundee world, then please get in touch with me. Let me know what you want to talk about and we'll offer you a slot into the January-February window. Highlights coming up for the rest of this academic semester. Next week, the Green Health Partnership, talking about promoting sustainable healthcare using behavioural change methods. 2 weeks later, the DCAT annual lecture with Raj Thacker. We've got genetics, ophthalmology, an update from Scott Gem, a presentation on public health about vaccine hesitancy, and we're finishing off the end of the year with dermatology, the Scottish Porphyria Service. But this week, I'm delighted that returning to Grand Rounds, the frequent flyer in this seat is Sarah Alstaff, one of our sexual health consultants, who has given many a talk at Grand Rounds right from the very beginning. Always popular, always very interesting, always entertaining. So I've teed you up there, Sarah. I was sat in Sarah's back garden in a socially distanced manner about sometime last year and asked her what impact does lockdown have on sexual health? Not just sexually transmitted infections, but on pregnancies and contraception and all the things that she deals with. And she said, well, that's very interesting. And I said, hang on there. Why don't you do a grand round on it? And I've finally pinned her down to this week talk about the impact that the pandemic has had on the work she does in sexual health. She has named this Pandemics Not Our First Rodeo. So I'm looking forward very much to hearing what Sarah has to say. If you have any questions, please put them in the chat. Please mute your microphones during the presentation. And Sarah, thanks very much. On you go.
Thanks, Tom. That's yes, no pressure there then. Yes, it was about a year ago, and since then there has been so much stuff to talk about, to share, which is why I have 11,000 slides. I may have tried to put too much into this. There are a lot of photos, so hopefully we'll just canter through. I did take out all my interactive Menti stuff in the interest of graphs, you will be pleased to know. So here we go. It won't come as a huge surprise to you that STIs, HIV, and COVID have an awful lot in common. And these were some things that just off the top of my head, lots of terminology that we both use, lots of common risk factors, lots of common approaches to managing STIs as well as COVID. But I'm just going to focus on a few things. I say a few, there's quite a lot. Bear with me. So first, we'll talk a little bit about sexual behaviours and outcomes during the pandemic. That's going to take up probably a good half of the presentation. A bit about COVID and HIV. Looking at what we learned from the HIV pandemic that we might have been able to use in the COVID response possibly earlier than we did. Not that it wasn't being shouted by people who knew HIV, but there we go. And finally, mostly opportunities posed to STI and HIV control thanks to the COVID-19 pandemic, hopefully. All right, so again, you will know that there is a common route to acquire both an STI and COVID. And I lifted this from a patient's triage form, actually, just within the last couple of weeks. Really interesting. He phoned us for a sexual health screen. He had flu-like symptoms for a week following sexual contact. He had a temperature and a cough. His most recent sexual partner had been female, and 10 days previously, he had had oral sex and vaginal sex with a condom with a casual female partner. So it could be on that occasion he acquired COVID. And so he was given advice to that effect, and we didn't see him for some time. So at the onset of the pandemic, we were busy sort of producing safer sex guidance for the pandemic, and it was largely following this kind of message that the safest sex is sex with yourself, so solo activities. Other activities that would be considered safe from a COVID point of view, possibly video chatting, sexting, cybersex, that kind of stuff, erotic stories, etc. Anything that didn't involve physical contact. Of course, sexual contact within your own household, where appropriate, was all right. So that we were putting out a lot of those messages, but weren't necessarily sure that people would take us up on that. There was also the sort of harm reduction advice. Actually, if you are going to have contact outside of your household, then there are additional precautions that you may wish to consider. From our experience with HIV, we do know that people can adapt to various threats. Something that we talk about with HIV is seropositioning. So different sexual positions may incur different risk of HIV transmission. So the same could be said of coronavirus, that there were safer ways to do it. I actually never gave this official advice myself, but we know that being outdoors is safer than being indoors. Not that we advertised that outdoor sex was the best thing to do, but finally, possibly the, I don't know. Again, I didn't ever promote the glory holes, but you can imagine that the glory holes also reduce your risk of COVID transmission. If you don't know what glory holes are, yeah, don't Google it. Don't Google it. And it wasn't long into the pandemic before we started to have stories of the great and the good falling foul of restrictions due to sexual contact with people outside of the household. The first, of course, being Professor Neil Ferguson, who in, I think, May of last year stepped down from the SAGE committee as he was having sex with somebody outside of his household. And the images that we will never be able to unsee again of Matt Hancock and again, somebody else outside of his household that he was having close personal contact with, certainly within 2 meters. Is that representative of the population? Well, the NatSal group wanted to look at that. So the NatSal is the National Survey of Sexual Attitudes and Lifestyles, and it's a large study that's carried out every 10 years. It is a mixed methods study. They do surveys, and they also do qualitative work, face-to-face interviews usually. And over the last number of decades, those results have been used to underpin sexual health policy, practice, as well as design research questions. So NatSal had been planning to do their 4th survey around this time. That was obviously deferred, and they did a special COVID edition. The kind of results that we get from NatSal include these. So looking at changes over the decades, what we can see between 1990 and the 3rd survey in 2012 is the number of partners that we have has increased over the 3 sort of cohorts, particularly in women. And another piece of data that's interesting that comes out of that study is the difference between the square at the bottom, our first sexual intercourse, the diamond, our first live-in relationship, and the spot, the birth of our first child, and looking at that over successive birth cohorts, depending when you were born. So you can see that people born, in the 80s, the distance between their first sexual intercourse and their first live-in relationship for men has certainly expanded quite a lot. So that is interesting data. It's not really relevant for this, but that's what NatSal does. So what did NatSal COVID do? So they undertook a web-based survey from July to August 2020. It obviously took some time to get it up and running, and by then some restrictions were already starting to be lifted. They surveyed about 6,500 individuals aged 18 to 59, largely representative of the general population, and they followed it up with some qualitative interviews. And what they found was that 1 in 10 people disclosed what they call intimate partner contact outside of the household, IPCOH. So 1 in 10 had reported intimate partner contact outside of the household within the previous 4 weeks, while there were some restrictions still in place. This was more likely in younger people. This was more likely in men rather than women. White ethnicity was associated with partner contact outside of the household compared with Asian or Asian British ethnicity, and it was more likely in sexual minorities. Intimate partner contact outside the household was also associated with other sexual risk-taking behaviours. So it was associated with people who had an increased number of sexual partners, people who were less likely to have or to use condoms, people where there was more alcohol use. People who were in health disclosed less intimate partner contact outside of the household, which was reassuring. But what was interesting is that intimate partner contact outside of the household was associated with what was called COVID experience. What we don't know is whether that was whether somebody might have had COVID and then thought, I'm not likely to get it again, I'll just take risks. Or it could be that, this is a measure of risk-taking behaviour. People who take sexual risks are also taking COVID risks. But what the data did show, the qualitative data showed that for people who did disclose partner contact outside of the household, deliberated about it, rather than it necessarily being a sort of flagrant disregard for rules. It was a carefully managed or considered choice where they might have mitigated that risk in other areas of their lives, or planned it. I'm not going to the nursing home to see my granny for 3 weeks, and so I'll do this now because that will give me time. Or actually, I work from home, I don't really see anybody anyway, and so etc. So that kind of thought process went on behind it. And so what the authors concluded is these weren't necessarily risk takers, but they called them risk managers, which I thought was interesting. Natsal COVID showed us that 1 in 5 people use sexual health services in the 4 months after lockdown. But 1 in 10 who tried to access services failed to access them. So that, and we know that there's huge disruption to sexual health services, and that was quite variable according to where you were in the country. 1 in 5 sexually active men were unable to acquire condoms, and for younger men that was 1 in 3. And I know this to be true because I do a monthly tutorial with the year 4s, and we have a challenge where they have to get a free condom and tell me how that went, getting the condom, and that went. And I discovered that a lot of the places where people would normally find condoms opportunistically had been removed. For example, student residences, condoms were removed. I think the staff were not wanting to promote the wrong message by having condoms available. However, when you lock down a student residence because of a COVID outbreak and people are on their own for 2 weeks, access to condoms is probably a good idea. Student unions, bars, other places where people might normally pick up condoms for free, those were not available. Another interesting piece of work that Natsal reported was that there was a perceived change in sexual relationships, that on the whole, 7 to 8% perceived a change in the quality of their sex life, and that was usually for the worse. However, 40% perceived a change in the relationship quality, and on the whole, that was for the better. So I found that quite interesting too, and that was of all people in a relationship. So, the data has to be interpreted in light of the fact it took place following the lifting of some restrictions. It's not necessarily reflective of what happened during those initial days and weeks of lockdown, that the restrictions were lifted at different times across the home nations. It's likely that due to social desirability bias that people underreported any sexual contact outside of the household. And it's difficult to know how much, if any, that contributed to the COVID pandemic in the UK, given that the vast majority of people didn't have intimate partner contact outside of the household. I'm just going to read one of their conclusions, which rather than try to paraphrase it badly, that public health messages need to recognise sex and relationships and the heterogeneity of circumstances, and that slogans such as hands, face, space may convey a concise message but do not reflect the complexity and nuance of people's households and relationships. And as the pandemic progresses, factors such as the need for intimacy, connection, relationship and sexual fulfillment do need to be weighed up against the risk of SARS. And you may be familiar with this kind of cartoon that was going around the socials back in the day. This one's slightly more comical, where they have COVID risk from low to high on the x-axis and non-COVID risk from low to high. bungee jumping while doing sword tricks maybe confers very little risk of COVID, etc. Singing in church is otherwise not particularly harmful, but a bit of high risk of COVID, etc. But there's nothing on here in relation to sex or sexual contact. There was kind of going on a Tinder date or getting a dental cleaning from a Tinder date might incur some risk. And of course, many of you may not be familiar with the terminology that's often used in our clinic, but throat swab is a thing that's not necessarily a sampling thing. So who knows, getting a COVID test in a bar from a stranger. This is a similar kind of graph, less comical, but again, looking at stratifying the risk of a number of day-to-day activities. And again, it'll come as no surprise to you that sexual contact or any level of sex is not mentioned on this, even though it's an activity that most adult people participate in at some point in their lives. So I think the stigma around sex and sexual activity and sexual behavior has contributed to a lack of good information to allow people to navigate that. So that's something that I think we can learn for the future. So that was about sexual behavior, what people actually got up to. I'm just doing a little time check. Not too bad. So what happened to demand for sexual health services in Tayside? So the first thing to say is that the data I have used for this is quite crude. There's probably good ways to clean it all up, but those ways were not at my disposal at 8 o'clock last night. So what we're looking at is episodes, and a patient episode is generated every time we have a new episode of care for a patient. So every 3 months, we would make a new episode for that patient if they presented again. But within those 3 months, if they're returning, we don't create new episodes or new attendances. So this isn't attendance data, this is episode data. So here we go. This is January 19 to January 20, pre-epidemic. I just wanted to highlight there was a drop in episodes February, March time when we changed the way we delivered care here from a walk-in service to a largely booked appointment service. So just to highlight that. But here we go. Here's January 2020, March, April, lockdown, and we created 65% fewer patient episodes in April 2020. However, by September 2020, our patient episodes were largely the same as they were the previous year, and in fact slightly greater than the previous year. And then by January 2021, when we had that second lockdown again, we created much fewer patient episodes. So what did we do in April 2020 when there were no patient episodes, i.e. patients to see? Well, I'll be honest, it was a long month. There was much sipping of tea, much resting of feet, much stroking of pussycat. But we got through. Just kidding, that's not what we did at all. We did spare you the delight of sexual health specialists being redeployed to the wards. We were not there to adjust your oxygen levels. You'll be pleased to know. So first of all, we turned our attention to the PPE crisis, and our first prototype wasn't great, didn't cover the nose. So we moved on to something that would cover both the nose and the mouth. And having nailed that successfully, we moved on, turned our talents to other activities. And don't worry, I thought that the condom concealed the face quite well here, so no one really knows who she. Wait, what? Hang on, sorry about that. Oh yeah, okay. So so we turned our talents to supporting the COVID response further. So what did we do? A lot of our staff went over to the community testing team. Acquainted themselves with new orifices above the diaphragm, and if you had a test done between the beginning of the pandemic and about August, it's likely that some of our staff might have been swabbing you. Most of what we did was supporting the results management for the symptomatic key worker program. Again, if you were tested early on in the pandemic and had your results by telephone, it was likely a sexual health staff member who chatted you through the results and what to do with them. So that was the symptomatic key workers, also managing outbreaks in both health and social care settings. We managed the test results for the Enhanced Community Surveillance Programme, which was done through the COVID assessment hubs in the community before COVID testing was widely available. And finally, for patients who were admitted to hospital and discharged without a COVID result, we would contact them with their COVID result, and that was the medical staff here within sexual health that did that. We produced a whole lot of data that was reported to the organisation and to the Scottish Government for the first number of months. And finally, and quite importantly, this fine gentleman here on the right, James, and another of our staff were sent over to Test and Protect, largely to provide some leadership, development, training, and supervision. And actually, they were there for a lot longer than any of us bargained for. But we're really proud of them and the impact that they had on that. And I think all of us have been really humbled and proud to be part of a program that was hailed as being an exemplar for other health boards. So the small part that we played, we were very proud to contribute to. Going back to what we were doing when we weren't doing all of that, how did we deliver care? So the National Sexual Health Leads agreed priorities, things that we would do, things that we wouldn't do. For example, we largely stopped doing skin problems, genital warts, things like that were not being seen in the early days. As time went on, we were able to put in place telephone consultations and also near me consultations. And this picture on the right is not far off some of what we did. We did a bit more empiric or syndromic treatment. People who disclose partners with STIs, rather than test them and treat them, we just treated them. And for some people, they were able to be signposted to community pharmacy, for example, with symptoms of urinary tract infections, candidiasis, BV, the rest of it. For patients that we were wanting to see, we would speak to them. We would do a consultation by telephone first before bringing them in to be examined and tested. Graham Leslie developed WABA clinics. WABA is a software for medical imaging, where patients could send in their medical images to WABA, which dermatology use widely, so that we could access those images and then do a telephone consultation. So that again worked well for skin problems, genital warts, herpes, etc. We were able to devise some kind of postal testing situation and roll that out. It's a bit rough around the edges and could do to be streamlined, but there is national work ongoing around sort of postal testing, online testing. Long-acting reversible contraception, coils, implants, etc., were stratified according to the patient priority, and the license recommendations were extended actually during lockdown. So for example, implants would normally have a 3-year expiry, but we're pretty confident that they're all right up till 4 years, etc., and the same for coils. I think, as far as I know, we were able to get on top of the menopause and psychosexual care actually during lockdown, because we were able to do a lot of that by telephone. My colleagues can correct me if I'm wrong, but I think that's what was going on with menopause and psychosexual care. If I've missed a lot of the other very important things that we do, I'm very sorry. So what type of people did we see? The chart at the top is looking at age groups, and that's the proportion of people belonging to 3 age groups, less than 16, 20 to 24, and over 25. And so the proportion of people that are over 25 has gradually increased. I don't know whether the younger people may be more supervised at home, maybe less at risk or less able to come in and see us, I'm not sure. Although that's on a background of us seeing less younger people than we did sort of 3, 5, 10 years ago. The graph at the bottom shows the proportion of people accessing us that are men who have sex with men, and at the key points, that sort of April 2020 and then January 2021, you can see that the proportion of people that we were seeing who are men who have sex with men was higher, which we would expect as priority patients and people more likely to present with acute STIs. So again, who did we see? This is looking at the SIMD quintiles, where 1 is the most deprived and 5 is the least deprived. And we know that our priority groups are generally in the lower SIMD scores, and they are more susceptible to poor sexual health outcomes. And we can see that in SIMD 1 from 2019 to 2021, the proportion of people that we're seeing that fall within the lowest SIMD scores is increasing, and it's coming down generally in SIMD scores 4 and 5. This is a really difficult slide, and I'm not actually surprised at all by it. This is the proportion of our female episodes where a history of current or past intimate partner violence has been disclosed. And you can see here that over the last year, up to 25% of our female patients are reporting current and past gender-based violence. I think I'd like to look at this data further, clean it up a little bit, look a little bit more at what's going on here. Are we just doing more reporting? Are we more sensitive to it, etc.? Although I think we've always been sensitive to it here. But what I can tell you is that through contact with the forensic and custody healthcare team, there was a 50% increase in sexual assaults reported to the police between 2019 and 2020. So this isn't something that we're seeing alone. And I would say anecdotally, and if you speak to any of our staff, there's a huge burden of people disclosing intimate partner violence. And I think that's quite exhausting actually for us here, that burden on us too. Looking at STIs, the proportion of chlamydia tests that have been positive. So this really just tells us that during April 2020, we did quite well at screening out those that were most likely to have infections. So the proportion of people, or the proportion of tests, chlamydia tests that were positive, it was up to 20%. But otherwise, looks like it's back to pre-pandemic levels, sort of hovering around the 10% mark, maybe slightly higher. The number of people with chlamydia, however, did kind of fall off. That's the number of tests that were positive. Of course, we did much less testing than we normally would, and there'd be much less testing in other sites as well, including primary care. So we were really seeing fewer infections, and as you may know, the majority of chlamydia infections are asymptomatic. 70% in women are asymptomatic, and 50% are asymptomatic. So really a drop off in the number of diagnosed infections, but there's likely a pool of undiagnosed infections out there. The proportion of gonorrhea tests which were positive, again, in April 2020, we managed to see the people who were most likely to have it, including the symptomatic. I did the graphanized gonorrhea color for you, so that's nice. And what we'll show in subsequent graphs, if we're looking pre-pandemic, we're looking at sort of 1% test positivity rate within sexual health, which before pandemic was up to more than 4%. So a sort of fourfold rise in gonorrhea cases pre-pandemic. And we're back to around that sort of 2 to 4% mark just now. And the number of tests that were positive, again, a fall off. Gonorrhea is more likely to be symptomatic, particularly in men. So we would expect men with urethral gonorrhea to present with symptoms. And so that's perhaps just what we're seeing here is the symptomatic men. But again, post-pandemic numbers are recovering, but perhaps this has been a bit of a firebreaker for gonorrhea. Looking at national data, though this is English data, is just available. You can see that rise over the last decade or so, and a slight tail off in 2020. And putting that into context of a greater history, gonorrhea is up here just now. We haven't seen this much gonorrhea since the end of the since the swinging 60s and the end of the First World War. So we are seeing monumental numbers of gonorrhea at the moment. And actually, we've had a couple of admissions in the last 2 or 3 months with gonococcal arthritis. So do be aware of disseminated gonorrhea. You are more likely to see it now than you have ever been before. Whether the STI bomb or the gonorrhea pandemic ever transpires, you will be sure to know when we call you up and redeploy you to the sexual health clinic wielding ceftriaxone for everybody. So new diagnoses of syphilis. This data is just from sexual health clinic. I have not included diagnoses that are made elsewhere, although largely we make the syphilis diagnoses, largely but not exclusively, as you will find out later in this presentation. Again, looking back over the last almost 20 years now of syphilis in Tayside, we had a little incident, not an outbreak apparently, in 2013. This was largely a heterosexual situation, and we had an incident in 2018, which was largely a gay and bisexual men situation. And you can see that 2020, despite everything, we had reasonable numbers of syphilis, and so far in 2020, without the final quarter of the year, we're already pretty high numbers. So again, syphilis is on the rise. Looking at English data, a large climb over a decade or so, and a small dip in 2020. again, looking at the broader historical context, we've never seen so much syphilis since the end of the Second World War. So again, you will see syphilis, you're likely to see syphilis. So keep an eye out for it. And on that note, the other photos, the photos other than the cat photos that you were hoping for. So this was a case that I saw in the last month or so, somebody presenting with a painless genital lesion. There was some inguinal lymphadenopathy, and you can see that's a pretty good looking chancre if ever I've seen one. Quite a raised border there, very indurated. It feels like there's a button under the skin that you could just pick up. You couldn't fold it in half because it's too indurated. Nice and clean. It's probably healing actually. And you can contrast that with this lesion that I saw in February of this year, a 35-year-old gentleman who presented with sort of ulcerating lesion, which turned out to be an invasive squamous cell carcinoma. So yes, we have also been seeing late presentations and complicated presentations. This guy I saw earlier this week, who had come in for asymptomatic testing. He's a gay man. His syphilis serology was positive. When I asked him about symptoms, he said he didn't have any. And when I specifically asked about rash, he said, oh yes, I've had this rash, but my GP said it was nothing. The patient said that his GP said it was nothing. And of course, he has this maculopapular rash, which is really coalesced into one great big patch. It's also on his torso, and nothing on the palms of his hands. You don't have to have lesions on the palms of your hands in order for it to be syphilis. So yeah, that was him, secondary syphilis. And on the same day, I saw this guy who had also presented, but diagnosed by his GP with a maculopapular rash, fever, flu-like symptoms, sore throat, and this rash, feeling quite fatigued. The guy on the left, his RPR was 1 in 8. The guy on the right, his RPR is 1 in 128. And although there is a classical syphilitic rash, syphilis is known to not obey the rules, and I wouldn't necessarily characterize the syphilitic rash in any particular way. You can see this one on the right is more papular than the one on the left, more erythematous, the one on the left more coppery. Syphilis does its thing. All right, secondary syphilis, be aware. And of course, syphilis is important, and this rise in syphilis is concerning. We're seeing an emergence of congenital syphilis in the West, including a number of cases reported in England. I think that this graph is really interesting, just looking at STI data in the United States. The top graph is chlamydia, the middle graph is gonorrhea, the bottom graph is syphilis. The red line is COVID. The gray line is the 2019 baseline comparator, I guess, graph, and the blue line is the infection in 2020. And again, you can see chlamydia fell off, and over 2020 gradually joined the baseline. Gonorrhea dropped off, but less so, and has now exceeded 2019's data, and syphilis never dropped off. All right, and is also exceeding the previous year. And I would stratify the associated risks of those infections that way, where chlamydia is quite endemic in a younger population, quite common, quite steady, but quite not necessarily a marker of high risk behavior. Gonorrhea more so, and syphilis more so again. I didn't have much on HIV, and I felt really terrible about it, so I chucked in a slide just to say that we continued with providing pre-exposure prophylaxis, so medication to prevent HIV infection to those who were still at risk through the pandemic. We did that largely by telephone, but we didn't stop providing pre-exposure prophylaxis. We considered it a priority. There's been a widespread reduction in HIV testing nationally, globally, and locally. We have been able to expand online testing, and that's something that we would like to do further to improve access to HIV testing. And concerningly, since the start of lockdown, we haven't had a single diagnosis of HIV, which is definitely a first. Does that mean there's no HIV infection out there? I'd like to hope that's the case, but I'm confident it's not. And so it's concerning that there are undiagnosed HIV infections that may be transmitted onwards. So over the next number of years, we'll find out. But again, this is in the background of, this is UK data, HIV rates in all risk groups coming down quite dramatically over the last number of years. You can see that in the green line on the bottom graph, HIV testing just dropped off during the pandemic, although the proportion of tests that were done online has increased. So yeah, that's something that we really need to recover. So just interpreting the STI data, we've had reduced access to sexual health services, and so we've not been doing the same number of testing. The sort of asymptomatic screening programs, again, no access to that, and that's important when we're trying to detect STIs. We haven't been contact tracing in the same way, and certainly rather than testing partners to generate new index cases, we've just been treating them epidemiologically, so losing those opportunities to then do further contact tracing. All data is likely to underreport infection rates because of the above, and that there are likely to be large pools of undiagnosed asymptomatic infections. And so you may see complicated STIs presenting in your area of work. All right, quickly, non-STI data. Community provision of emergency hormonal contraception. So quite a lot of morning after pills provided in community pharmacy. Again, that dropped off at the initiation of the pandemic, but again, recovered. All right, now that could be because of lack of access to more reliable forms of contraception provided either through primary care or through sexual health services. It's difficult to unpick that. Or is it a marker of just the same risks continuing pre and post initiation of lockdown? This, again, is very crude data from our department. There's so much more we could unpick, but again, last night I didn't do that. But this is episodes where it was noted that they presented for either complex contraception, emergency contraception, or routine contraception. We don't provide much by way of routine contraception here, so I'm imagining that mostly relates to long-acting reversible contraception. So that dropped off at the two severe lockdowns, but you can see that actually our routine contraception provision recovered, and we were able to put on more LARC clinics to catch up with that, and also to pick up some of the displaced work from primary care. Termination of pregnancy. Again, here is where lockdown started. No significant decrease compared to previous years of people seeking termination of pregnancy. And actually in August and September 2020, there's a rise here, which I find really interesting. Again, was it due to perhaps not being able to access reliable contraception earlier on? Is it due to perhaps some of the financial and economic considerations of continuing with a pregnancy during the uncertainty of the pandemic? And so, yeah, so interesting data there. Looking at Scotland's TOP data, we have amongst the highest rates of termination of pregnancy, and actually our TOP provision increased during 2020 compared to the previous year. And this is Scotland data as a whole. We can see that the proportion of medical terminations that are provided by early medical at home has changed dramatically, and actually that's been good during the pandemic in terms of avoiding bringing people up to the hospital, and it makes it more accessible for them. The other thing with termination of pregnancy that changed during the pandemic is that we were finally able to offer self-referral, that people did not need to be referred by their GP or sexual health, which was the previous case, that they could now refer themselves, again, cutting down the number of people that are involved in the pathway and improving accessibility. So I think we've spoken about that, and in the interest of time, I'm just going to move on. All right, looking at COVID and HIV. The first thing to say is COVID or HIV, all right? And so there are actually lots of case reports now of people presenting with late-stage HIV, pneumocystis pneumonia, being diagnosed as possible COVID-19 when in fact they have PCP, and also cases of co-infection with or without HIV. We'll talk about that a little bit, but yes, don't forget things like PCP. PCP caused by pneumocystis jirovecii, for those of you who are a little bit longer in tooth. We used to call it pneumocystis carinii pneumonia, and we can still get away with calling it PCP because of the cystis pneumonia, so that works well. PCP occurs in people with advanced immunosuppression with a CD4 count usually less than 200, although it can be higher than that, particularly in older age groups. It's quite an insidious onset, so 2 to 4 weeks of dry cough, shortness of breath, fatigue, etc. And you may also have associated symptoms and signs of immunosuppression. There may be weight loss, there may be oral candidiasis, you may see lesions of Kaposi sarcoma, etc. But they don't have to have these things. Now, I read this in a book. Don't ever ask me to interpret a chest X-ray. But I believe that we are finding bilateral symmetrical interstitial changes in PCP, largely hilar extending out from the hyla and characteristically sparing the peripheries. So I guess this means down here and possibly the apices. Progression would be to cystic changes and to spontaneous pneumothorax. So that's what you might see in PCP. And I think that some of these changes are quite typical, the ground glass changes of COVID, which maybe has a predilection for the extremities, but somebody can correct me if I'm wrong. To diagnose PCP, it would largely be on bronchoalveolar lavage fluid where you would undertake immunofluorescence or increasingly now just PCR testing. And so just comparing and contrasting COVID with PCP, if your patient has a longer duration of symptoms, more of an insidious onset, you might want to consider that. Dyspnea is far more common in PCP. Again, I know with COVID, you might see low or high lymphocytes. In the case of PCP, they're almost always going to be low, and you would look for associated symptoms of advanced immunosuppression. We've spoken about the differences in radiology. If you gave somebody with PCP steroids, you might expect to get a transient improvement, but ultimately the infection and the disease would progress. We do use it as an adjunct to cotrimoxazole in people with severe hypoxia. And of course, in COVID-19, there have been case reports of people developing PCP due to the immunosuppression associated with COVID-19, the immunosuppression associated with prolonged corticosteroids, and also it's been reported with the use of biologics in people with, for example, rheumatoid arthritis. So just some complications there. All right, so do think PCP, don't forget about HIV. And actually in some centres, particularly with higher prevalence, HIV testing is routine on their admission panel when people present with possible COVID. The other thing not to forget is primary HIV infection when you're seeing somebody who might have an acute viral illness. Up to 80% of people with acute HIV infection will present with symptoms in the early weeks, again, 2 to 4 weeks after exposure. Fever, maculopapular rash, myalgia, pharyngitis, possibly headache or aseptic meningitis, and in severe cases, ARDS has been reported as well as multi-organ failure. And at that stage, they're very highly transmissible. So it's a really good opportunity to diagnose them, treat them, and prevent onward transmission. So when you see somebody with what might be a virus, consider that it might be a virus and that virus might be HIV. During the last year, our national guidance for HIV testing has been updated. The only things to really point out is that the window period for the 4th generation test has changed from 28 days to 45 days. I think you're only gaining 2 or 3% in terms of sensitivity, but that's what they did. So fine, 45 days, just over 6 weeks to confidently exclude HIV on a 4th generation test. The indications for testing are largely the same. Universal testing should be offered in, universal testing means testing in all primary care, secondary care, and emergency settings in areas where the prevalence exceeds 2 in 1,000. TASELI does not meet that criteria, and hopefully we won't. Opt-out testing in some clinical settings like sexual health, like termination of pregnancy, drug addiction services, opt-out testing for high-risk groups. People presenting who belong to a high-risk group should be offered testing regardless of how they present. And then finally, indicator conditions. And the indicator conditions I've charted here by specialty. I didn't chart them by specialty, the guidelines did that, but I had to transpose them all. So look up your specialty and see when you should be testing for HIV, either because that condition may be AIDS defining in someone living with HIV, or because the prevalence of HIV in people presenting with that condition is thought to be greater than 1 in 1,000. And just to put a magnifying glass on some of the virally respiratory type things. Recurrent pneumonia is AIDS defining, so that's more than 2 or more episodes in a year is AIDS defining in someone living with HIV. A mononucleosis like illness should be tested for HIV, anyone with unexplained fever, any community acquired pneumonia, and any invasive pneumococcal disease. I know, controversial. And these people should be tested for HIV regardless of yours or their perceived risk for them having HIV. Don't do a risk assessment. Don't ask them all those intrusive questions. Offer them an HIV test and move on. All right. Just like happened to a 20-year-old cis gentleman who presented in the last week or two with a 2-week history of pharyngitis, fever, and a widespread maculopapular rash. He had a regular female partner of 3 months duration. His partner is a cisgendered female. And he went and saw his GP FY2, who thought, sounds like a viral infection. But this GP FY2 was not satisfied with a viral infection. He wanted to know which viral infection. And so he did some further tests, and the ALT was elevated, the CRP was elevated. He tested for EBV. Although the IgM was positive, the IgG were positive, suggesting previous infection. CMV, IgM, and IgG were positive. Might have had a recent CMV infection. Now, crucially, the GPFY2 had thought this could be seroconvergent illness. I'm going to do an HIV test. And it was negative, which makes this particular case presentation less exciting, but better for the patient. But it doesn't stop there, because this GPFY2 knew that pharyngitis, fever, and a widespread rash might also be secondary to syphilis. Secondary syphilis, and did antibody test, which was positive with the RPR of 10128. That was one of the photos I showed you from earlier this week. So the tagline here is "Be More Dr. Adam Harvey, FY2 of the year, who diagnosed secondary syphilis in a low-risk person presenting with viral symptoms." All right, think HIV, think syphilis, don't miss it. Yeah, and the last thing to say about that is I did about pat myself on the back for being such a great teaching lead for sexual health to discover that he trained elsewhere, which was a sad shame for me, but great for them. So moving on, where am I with timing? Oh my gosh. Are people living with HIV more susceptible to getting COVID? There is a systematic review looking at obviously a number of trial data showing that they may be more likely to acquire COVID. Is that because they're more likely to mix? Is it related to the inequalities? Is it related to crowding? It's not clear. But the pooled prevalence of HIV in COVID patients was on average 1.22, but was up to about 5% in COVID patients in Seattle. Go Seahawks. Does HIV alter the natural history of COVID-19? It's largely a similar course, I would say, from what I understand. There's no evidence of increased viral load, COVID viral load in people living with HIV, although we know that any intercurrent illness can cause increased transcription of HIV and increased viral loads. And there's no evidence of any increased transmissibility. What about outcomes for people living with HIV? Well, the earliest data, so at the outset of the pandemic, all the great and the good in HIV were telling us that there was no increased risk, which was a difficult message when HIV is characterized by a dysregulated immune system and your patients are almost invariably susceptible to severe outcomes from infections, particularly viral infections as well as fungal infections. So I didn't feel entirely comfortable with that. But on the other hand, severe COVID disease was associated with these cytokine storms, and perhaps our patients weren't capable of mounting those cytokine storms. So there were explanations. The first population cohort studies came from both the UK and from South Africa, reporting high ventilation and mortality rates in people living with HIV who got COVID. But there weren't enough data to account for confounding factors, including demographics, ethnicity, healthcare systems. Comparing data from South Africa, people living with HIV in South Africa is very different from the West. And crucially, these studies did not look at HIV-specific data, CD4 counts, viral loads, ART status, etc. but did highlight that there was probably this, what we call syndemic epidemics, where a lot of the underlying factors that put people at risk of HIV and poor outcomes were also putting people at risk of COVID and their poor outcomes. And you add these things together and you have what's called a syndemic epidemic. When the matched case control data actually did show that the difference between outcomes in people living with HIV and people living without were less different, and in some studies reported no difference. The factors that have been shown to be associated with poor outcomes in people living with HIV is age. The average age of COVID patients, the average age of inpatients with COVID who are also living with HIV was a decade younger than HIV negative. If they've ever had a previous AIDS-defining illness, if they have a detectable viral load, if they have a low CD4 count, although a low CD4 count was less important where the viral load was undetected. Any comorbidities as well as frailty increase the chance of ventilation and mortality in people living with HIV with COVID. Do antiretroviral drugs treat or prevent HIV infection? You'll know from the recovery study early doors that Kaletra, which we don't use anymore, but used for a long time for HIV, did not show any improvement. And the darunavir, ritonavir, another protease inhibitor, didn't show any anti-SARS activity at clinically relevant concentrations. Why does this keep flicking? So looking at tenofovir, a meta-analysis showed that people who are on tenofovir, disoproxil fumarate, which is an NRTI used in combination with other drugs, that those people had the lowest risk for both COVID diagnoses, hospitalizations, ITU, and death. Different studies reported different outcomes, but it was thought that tenofovir was possibly a surrogate marker for reduced comorbidities, because people with a lot of comorbidities, particularly renal failure, may not be on tenofovir, and that might be accounting for those apparent results. And when they looked at HIV negative individuals on and off pre-exposure prophylaxis, individuals on pre-exposure prophylaxis with tenofovir did not have lower rates of COVID seropositivity than people not on PrEP. What about vaccines in people living with HIV? Will they work? Do our patients mount an immune response? And there was a study published in The Lancet by Frater et al. Showing that with the Oxford vaccine, that study participants mounted a similar response, no increased adverse events, and similar responses, antibody as well as cell-mediated markers of cell-mediated immunity. Unfortunately, the majority of these people living with HIV were male, almost universally white, on antiretroviral treatment with good CD4 counts, so not necessarily representative. People involved in the mRNA trials who were living with HIV have also been shown to have comparable antibody responses. So that's promising. But of course, we do worry about efficacy in people with high viral loads, low CD4 counts, comorbidities. And in terms of areas, where there's a lot of HIV, for example, sub-Saharan Africa, will the COVID vaccine benefit those groups in the same way? How long does protection last, and its activity against the Delta variant? One of the things that has concerned me most with my patients is the overlapping vaccine hesitancy as well as ART hesitancy. A lot of our patients belong to marginalized groups where there's sometimes difficulty in trust with institutions, but there has been particular concerns about the vaccines in women of reproductive age and also in people who experience racism. So that's a concern in terms of uptake in our groups, both locally, nationally, globally. So our patients were prioritized in group 4 if they were particularly immunosuppressed. Otherwise, they were all included in group 6. And for those particularly immunosuppressed, they've been offered a third vaccine dose. So that's just a summary slide. So I will canter on, hopefully be done this in good time well, it won't be a good time now, but in time. What did we learn from the HIV pandemic that could be applied to the COVID-19 response? So from our first rodeo with pandemics, what could we apply? The first thing is stigma. I've been so aware of it over the last year or so. Stigma as pertains to COVID. Stigma is defined as the shame or disgrace that is associated with something that is considered socially acceptable, and it results in marginalizing those people and ostracizing these people. And we know that stigma does not solve the problem. A student asked me in a tutorial a year or two ago, isn't stigma a good thing because it acts as a deterrent for that activity? But it doesn't. All it does is it puts it underground. It stops people coming forward. It stops people from testing. It results in fear. So stigma is no good. I did worry a little bit about this particular campaign that we seem to be promoting, which all seem to be fueling stigma and shame and blame associated with COVID risk activities, particularly amongst young people. We know that they don't respond to that type of messaging at all. And I thought that this type of messaging was much better about harm reduction. All right, how do we make things safer? We always talk about safer sex rather than safe sex. How do we make something safer? I like this riskometer thing, and where you can put yourself on that riskometer. So how do we support people to do things they want to do, but as safely as possible? Criminalization fuels transmission. We know this, all right? We know this from HIV. There's absolutely no evidence that criminalizing transmission of an infection results in less infection, okay? It creates barriers to testing. It creates barriers to people accessing care. It fuels the stigma. People with COVID are bad. They should be in jail. If they transmit, that's a bad thing. Same with HIV. And we know that that fuels onward transmission. Criminalization has the greatest impact on people who are most vulnerable, most marginalized, people who are already criminalized, and sidelines human rights. And really our prevention efforts should be ground in human rights, ground in scientific evidence, and that we need to engender trust between communities, healthcare policymakers, lawmakers, politicians, police. We're almost there. I'm going to do this before 2 o'clock. It's going to be awesome. We know that building community is effective in prevention. This little guy on the right we designed when we did our men-only Tayside Clinic for gay and bisexual men, where involvement of volunteers from the community was essential to us establishing that service, which was very successful. We have to consider how we talk about patient groups, rather than talking about hard to reach populations. We have to consider the fact that actually these are people that find us hard to access, information difficult to access, support difficult to access, and communities within, champions within communities are really credible resources for these individuals who find it difficult to access the care that they need. And we're just so almost there. Other lessons learned. We need to address health inequalities. I don't know how to say that. I can't overemphasize that. If we don't have vaccine, we know that the disruption to provision of HIV care has been disrupted by COVID. If we don't get COVID vaccines to sub-Saharan Africa, then HIV is just going to get worse. People are not going to have care, they're going to transmit it on. And so not only is COVID going to be worse, but HIV is going to be worse. One size does not fit all. We have to tailor our prevention. Trust, as I said, is as important in tests. And the role of activism, this picture on the left was a condom that was put on Jesse Helms' house back in the 80s in protest against some of the policies around HIV in the States at the start of the HIV pandemic. And the same activists have actually delivered a mound of bones to Joe Biden's chief of staff just in order to protest again, trying to get global access to vaccines. Tony Fauci and Peter Staley. Peter Staley is an activist who's a bit of a hero of mine, and they have that trust. But Peter's also continues to be an activist. That's him here. He was responsible for this and for that. And there's a couple of resources if you're interested in a life of activism. Tony Fauci would argue forcibly with anybody that had the HIV pandemic not helped train vast armies in the scientific, medical and public health sectors to mobilize in a moment of crisis, the battle against COVID-19 would be much further behind where it is today. So he thinks that the HIV pandemic has helped the COVID pandemic. And so we hope that we'll get something back from that once this is all over. what's in it for us? I hope that we have re-galvanized the scientific and public health community, and we can channel that into ending HIV by 2030, which is the UN AIDS target. That the new infrastructures that have been created to reduce health inequalities can become permanently embedded, that we can continue to prevent preventable diseases like HIV and STIs. I think the community has developed a fluency in the language of infection prevention, which I think is really helpful. Window periods, incubation periods, PCR testing, lateral flow testing, all of this kind of stuff is really useful. Please, can we have progression of HIV vaccines? Hopefully, the technology that supported the development of COVID vaccines can go on to finish the job it was started for. And also the development of testing technologies which are scalable and affordable for rapid diagnosis and testing and prevention of STIs. And please, finally, dear God, can we have an app for contact tracing? Yes, for the love of everything that is good, we just want the app, please. Thank you very much. Thank you to the various people who provided me with data. I probably don't have time for questions, but here we go. Stop.
There's always time for questions, Sarah, don't worry.
I'm exhausted.
Yeah. So we still have 50 people hanging on to your every word. And I should have mentioned at the start, I was looking forward to photos of cats and cushions, and you didn't disappoint. So thank you for that. Now, there are a couple of comments and questions. For Ellie Hollisall, says, not a question, but just to reinforce Sarah's earlier comment about the amazing work from the sexual health team in the early days of COVID testing and contact tracing. It was so great to work with such a fab team. And I can definitely confirm that you were doing that, Sarah, because you were the person who phoned me to tell me that I had COVID on April the 13th, 2020. So you were definitely right in the middle of that. And I should mention, she'll not like me for saying this, but she sent me a text message every day for the next fortnight to check up on me. So thank you so much.
I had a virtual COVID ward round, actually. You were one of about 3 at that time, friends of mine who all had COVID. So I did a ward round.
Well, now I feel less special, but still, that's great. Wendy McMullen says, fantastic talk as always, Sarah. There may not be time for questions. Yes, there is. The proportion of women reporting sexual violence is truly shocking. I think everyone in the audience will agree with that. Do you think that non-SRH colleagues, including gynae, are doing enough to screen for this in assessing elective and emergency patients? Wendy has turned her camera on, so if you want to add to that, Wendy, please do say.
No, that's fine. That was my question. Thanks, Sarah.
I think one of the, I don't know what happens in other services. I think one of the things, we've been kind of reflecting on it recently. One of the things that we have the benefit of is time. Here, our appointments for patients are often, for a new female patient, maybe 40 minutes. And so I feel that we have the benefit of time. We're quite holistic in our approach to assessing patients. I think we've all been trained in trauma-informed care. And so sometimes the language that we use, but also the relationships that we built up with patients. But I had, last Friday, I had an 18-year-old. It was my last patient of the day. And I was 2 hours with her after a long history of a lot of abuse, neglect, exploitation, grooming, etc. in the past. And it was at 5 to 5 when I thought, I'm going to get her out of here, when she asked, is everything here confidential? And I was like, oh no, here we go. There's going to be some crazy disclosure, which of course there was. So I do think that other services don't have that benefit of time. And I'm pretty sure that you can't create that time. So it is a privilege that we have, and we're still able to work with that at the moment. But yeah.
It's been publicized, perhaps not widely enough, the extent of the increase in violence, in domestic violence, and I've seen that slide before, but it's still quite shocking. I was interested, well, in all of it, but particularly in the medical diagnoses of HIV being perhaps missed because we're so focused on COVID. There is a patient I've seen in the last week who I'm pretty convinced has PCP as a consequence of tocilizumab given to treat severe COVID, and I think he probably would have died if he hadn't had the tocilizumab, but now I'm pretty sure he's got PCP, and we have seen other opportunistic infections following significant immunosuppression in the same way. And we are a service that does tend to pick up a reasonable amount of HIV because of chest infections.
Yeah.
I do wonder if we've reduced our testing because our mind's been off the ball a little bit. So it's been an apposite time for you to say this.
Well, what I wanted to ask, I'd hoped to speak to John Schoen beforehand, because I just thought I wanted to ask him what is the additional cost in terms of the testing costs associated with an episode of COVID. Really, what's the additional cost of an HIV test, and what have you got to lose? So yeah, I think that there is a sort of diagnosis bias in the context of the COVID pandemic, understandably so, but perhaps it's an opportunity to embed routine HIV testing. Again, at a time like this, I don't think we've got much to lose.
And the same is to be said, I think, of seasonal viruses. There's lots in the news about the super cold. I expect, well, actually, when you do, if we test for this, it's just adeno, rhino, the normal sort of stuff. But we've not tested for it because we've only been testing for COVID, and we've started to do a lot more testing for seasonal virus PCR now to try to pick up on that, get back to normal business. But,
yeah, I often, when I'm challenged by HIV testing, sometimes from primary care, that sort of, the cost effectiveness of HIV testing, but I always, and maybe someone can argue with me, I always question the value of doing EBV testing. I mean, it's nice to have a diagnosis, but further to that, I'm not sure what it adds. Compared to HIV testing, there's so much more to be.
Tony France always used to say that we were very close to HIV testing for everyone who comes to the front door, but we never quite reached it. How close are we?
I think the last prevalence I am aware of is about 1.5 in 1,000 locally in Tayside, and the cost effectiveness for universal testing is at 2 in 1,000, and that's for at 2 in 1,000 you would test everybody who in primary, secondary care and emergency settings who are having venipuncture. At 5 in 1,000, you would actively venipuncture them in order to do an HIV test if you weren't doing so otherwise. So at 1.5, we're not there, but I think that makes it more challenging because then you have to know your clinical indicators and you have to know your risk groups, etc. And we know from studies that even when you do universal testing, there's evidence that people still target testing when we shouldn't be. It would be so much, although I don't want the prevalence to go that high, it would just be so much easier if we just tested everybody. And it's interesting because patients just think that one of those guys with syphilis, the one that hadn't been to Dr. Adam Harvey, FY2 Spectacular, the other one said he'd been to his doctor and had tests for everything. And I think some patients just think that, the blood just goes in a machine and pings for everything that's not right. So there is a thing about how we consent people for testing, what they're being tested for. I think is important.
Okay, no more questions on the chat. And it is 2:07 now. So we'll say thank you very much to Sarah for a fascinating talk as always, and thanks for pictures of the cat and the pillows. And we will see you all next week, where Viola Marks will be speaking about promoting sustainable healthcare using behavior change methods. There will be lots of slides of people on bicycles, so tune in for that. All right, thanks so much, everyone. Thanks, Sarah. Take care. We'll see you next week.
You're welcome.